from the WASH in healthcare facilities. And then we also conducted our own rapid assessments across the country. And then in 2019, learning from what we had done with the first project, we realized that the program was we developed a full program, a 5-year program, and our target is to support 150 healthcare facilities. This is to be done directly by WaterAid, and then also bringing on board other stakeholders to support. And the reason we developed this program is due to the increased demand for WASH services in the healthcare facilities. And then also realizing that the challenge of AMR is here to stay, and there is need for us to do something about it. How we are doing our work, we are complementing the government efforts on the commitments to the WASH in healthcare facilities resolution made at the World Health Assembly. We aim to demonstrate the intersections of WASH and IPC. This is done by modeling programming of workable and innovative interventions. Next slide, please. So our delivery approach is that we are providing a comprehensive WASH package with integrated behavior change interventions on sustainability and hygiene. And the package includes changing physical environment. That's where we are doing construction works and rehabilitation of WASH infrastructure, and also development of sustainability plans. And then we are also building capacity on operation and maintenance and the management workable management models, so that the management in the targeted healthcare facilities are able to maintain the infrastructure and ensure the environmental cleanliness. And then we are also supporting IPC and hygiene behavior change through trainings and mentorship. And we also conduct advocacy at all levels to influence strategic and sustainable financing for WASH in healthcare facilities, as well as preventive maintenance of infrastructure. Next slide, please. So just a summary of the activities that we are conducting in the healthcare facilities. That's providing water supply, reticulated water supply, ensuring that the healthcare facilities, they have adequate water supply for cleaning, hand hygiene, and any purposes required in a healthcare setting. Construction of inclusive sanitation facilities designated for clients and healthcare workers, because we know that if we don't have adequate sanitation, chances of having open defecation within the surroundings of the healthcare facilities is also high, which also compromises the environmental hygiene within the healthcare settings. And then we also install hand hygiene facilities in all points of care, as well as construction of waste management facilities. And then we build the capacity on operation and maintenance of infrastructure, targeting the healthcare facility staff and the support committees from the communities which work closely with the healthcare facility management committees. And we also we provide some trainings and ongoing mentorship for the operation and maintenance committees. And then in terms of infection prevention and control and hygiene, we support training and refresher trainings for all cadres, and the trainings are usually conducted by the national trainers under the Ministry of Health, and all we do is provide the necessary resources that the trainings can be conducted. And we also support routine monitoring of implementation of facility improvement plans, and the provision of visual aids and cues for reminders on IPC protocols and hygiene practices in strategic places, and we do conduct hygiene promotion activities targeting the health workers and also clients to influence behavior change. And on advocacy, we engage with our stakeholders, the district health office, as well as the local councils, to provide resources and prioritize preventive maintenance of the WASH infrastructure. And we are also supporting community-based fundraising efforts because we know that the communities have also a role in ensuring in ensuring sustainability as well as adequate availability of the WASH resources. And we also strengthen some feedback mechanisms on the quality of care that the clients are receiving, which also includes the WASH services and any feedback on the WASH levels of WASH services that they are facilitating. And we also do our advocacy work through participation in the health cluster meetings and other strategic engagements, because we know that as an organization, we can only reach few healthcare facilities. But as government, if it prioritizes WASH in healthcare facilities, more and more healthcare facilities are going to benefit, and we'll see an improvement across the country. Next slide, please. So currently, we are focusing on providing comparing evidence to influence health sector players that are not in WASH to invest in WASH infrastructure and the IPC in healthcare facilities. Also innovate and produce innovative and exciting training materials on IPC WASH for healthcare workers as well as WASH professionals, because there are times when people have a feeling that IPC is to do with the medical personnel, but there are other stakeholders within the health sector who may not be necessarily medical people, but they have a good understanding of WASH and have the role to play in ensuring that there is environmental hygiene in the targeted healthcare facilities. And we are also ensuring district health offices and the district councils honor commitments on sustainable management of WASH infrastructure, because we know that WASH and IPC in healthcare facilities is a multi-sectoral issue. So we want every stakeholder to play their part in ensuring that we are providing the right services. Next slide, please. So as we move forward, our recommendations and the things that we are talking with our various stakeholders is utilizing the World Health Assembly resolution as an accountability mechanism for seeking greater government commitment in implementation of national roadmap for improving WASH in healthcare facilities, as well as the progress reports on the same, because we know that without financing, it is difficult for us to have the clean environments within our healthcare facilities. And we also want WASH programs for healthcare facilities to include capacity building for sustainability planning and financing mechanisms for infrastructure, because most of the funding that we have on and functionality that we have is due to lack of regular maintenance, and of course sometimes due to vandalism. But then if we have allocated financing, we should be able to address any non-functionality in good time. And then there is also need for collaboration among development partners to hold government accountable at all levels in the management of the WASH infrastructure before any new investments, because there are also times when the appetite for new things is very high, and that also frustrates efforts of having sustainable services. And then we also need to have comprehensive interventions. WASH programming in healthcare facilities cannot achieve intended impact minus IPC, because there are others who just come and do the infrastructure component and off they go. But then if we do comprehensive interventions, that will help us to address a lot of issues and the problems. Next slide, please. So, in conclusion, I'd say that a dirty health hospital can be a disease breeding ground. It needs to be cleaned all the time, and water is the key ingredient. Thank you so much.
Thank you very much, Natasha, for the country experience that you have shared with us, and also emphasizing the point of ensuring that the WASH issues are in place. And at this point in time, I would like to invite Dr. Wande from AfricaCDC, who is going to take us through the question and answer session. Dr. Wande, welcome, and over to you. Thank you.
Thank you very much to the speakers, and good afternoon, good morning, colleagues that have joined. We have quite a number of questions for Prof. Dide and Ms. Natasha from WaterAid. So I will be posing the questions to two of our speakers, and of course, we have panelists from WHO, ICANN, and AfricaCDC, who would be able to take some of the additional questions. So colleagues, the question, use the Q&A channel because that's where we'll be reading off the questions from. So starting off very quickly with you, Prof, is to say, there's a question here that says that, please advise how important bare below the elbows are in healthcare, in combating healthcare associated infections in the hospital. We are struggling to get compliance, especially from the doctors, because they keep saying there's no evidence that indicates BBE can reduce healthcare associated infections. So over to you, Prof, to give some answers or some insight to that question.
Can you hear me?
Yes, we can now.
Okay. Yeah, well, it's an interesting question because the bare below the elbow has never, ever been demonstrated as bringing any significant advantage over the hand hygiene compliance. So in my institution, the bare below the elbow is not even not a rule. So I know that there are many places, and in particular in the United States, where they are crazy about the bare below the elbow, but I don't think it's appropriate. I think that you should concentrate on what is the most important and not on something that is less important. Hand hygiene by itself, the recognition and the knowledge of the 5 moments for hand hygiene, the fact of using a promotional strategy that has 5 elements that, as I said, system change, training and education, reminders in the workplace, safety culture, monitoring the performance and feedback of the performance is a lot more important than making rules and regulations such as bare below the elbow, for which there is no evidence. So I think that in infection prevention and control, we should really be very careful not to put too much energy onto strategies that are not evidence-based, because it makes us lose credibility. So in my institution, you will see me like this, you know, with my bare below the elbow, because that's the way I behave. But you cannot say that there is any evidence behind that, and you should not fight too much to find it. If the institution make it a rule, okay, then people should follow the rule. In my institution, I have decided, and we have decided, not to make a rule, because I don't want to fight for a strategy that is not evidence-based. So that's maybe some of you may be surprised. I have been defending this strategy for the past 20 years and even the past 10 years. There is still no evidence-based sort of paper or study that show the advantage of the bear below the elbow. So this is my answer.
Lizzie?
Yes, Dr. Wande, I can hear you.
Okay, fantastic. Sorry, I think the network went off for a bit. Prof, thanks for that answer. I think you've got a few more questions. Some are quite interesting, particularly because most of our participants are based on the continent. This is really a continental initiative that we have been doing since 2020 to strengthen the capacity of healthcare workers across Africa, as well as other low and middle